Hello. Welcome to the CNS Active Medications, Risk of Falls and Fractures in Older Individuals microlecture. My name is Rebecca Brynjulsson. I'm a board-certified geriatric pharmacist and School of Pharmacy faculty member at North Dakota State University in the School of Pharmacy. Objectives. At the completion of this presentation, the participant will be able to: Number 1. Identify recommendations from the 2023 AGS-Beers criteria surrounding the use of CNS active medications and the risk of falls fractures. Number 2. Describe the methods and findings in the following research articles. Number 1. Association between medications acting on the central nervous system, medication burden, and risk of serious falls and hip fractures in Veterans Affairs nursing home residents. And number 2, association between medications acting on the central nervous system and fall-related injuries in community-dwelling older adults, a new user cohort study. The citations for these articles appear on the screen as well as in the reference section. In 2023, the American Geriatric Society, AGS, updated the AGS-Beers criteria and published the update as a special article in the Journal of the American Geriatric Society. The citation for this article is on the screen before you. This article is an evidence-based guide for practicing clinicians to identify potentially inappropriate medication, PIM use in patients 65 years and older in ambulatory, acute, and institutional settings. It is noted that these guidelines do not apply to settings where patients are in hospice or receiving end-of-life care. Let's see specifically what the AGS-Beers criteria has to say about CNS active medications and the risk of falls and fractures in older individuals. If you recall, the 2023 AGS-Beers criteria are organized into 5 tables with the following titles. 1. Medications considered as potentially inappropriate, Table 2. 2. Medications potentially inappropriate in patients with certain diseases or syndromes, Table 3. 3. Medications to be used with caution, Table 4. 4. Potentially inappropriate drug-drug interactions, Table 5. 5. Medications whose dosages should be adjusted based on renal function, Table 6. The quality of evidence ranges from low to high, and the strength of recommendation ranges from weak to strong. CNS active medications appear on multiple tables throughout the Beers criteria. Table 3 and Table 5 have criteria to help to address minimizing the use of CNS active medications to minimize the risk of falls and fractures in older adults. This will be the focus of today's presentation. Participants are encouraged to review the 2023 AGS-Beers criteria to assure that they understand the recommendations surrounding CNS active medications that may be more commonly used in their practices, noting that the medications discussed may have additional rationale and recommendations to avoid use due to risks not related to falls or fractures. First, Table 3 identifies, quote, potentially inappropriate medication use in older adults due to drug-drug or drug-syndrome interactions that may exacerbate the disease or syndrome, end quote. We see the following medications are associated with a history of falls or fractures: anticholinergics, antidepressants, specifically the SNRI, SSRI, and TCA classes, antiepileptics, antipsychotics, benzodiazepines, non-benzodiazepine, benzodiazepine receptor agonists, hypnotics, otherwise known as Z drugs as listed in the table, and opioids. The rationale for this recommendation is as follows. Quote, may cause ataxia, impaired psychomotor function, syncope, or additional falls, end quote. There is some additional medication class-specific information provided for guidance in both the rationale and recommendations. It is good to note that if a CNS active medication is to be used, that it is recommended to minimize the use of other CNS active medications that also increase the risk of falls and fractures, along with other strategies to prevent falls. This is a strong recommendation with a moderate to high quality of evidence depending upon the medication class. Next is the recommendation from Table 5, titled, quote, potentially clinically important drug-drug interactions that should be avoided in older adults, end quote. Here we see the medications that were previously listed in Table 3, but divided into 2 different rows in this table with recommendations. The first recommendation is related to anticholinergics. There is a separate table in the 2023 AGS-Beers criteria, Table 7, that lists medications with strong anticholinergic properties. Using more than one medication with strong anticholinergic properties increases risk for several adverse effects, including falls or fractures. There are several different assessment tools that can be used to assess a patient's anticholinergic burden to help inform practice decisions. There is a citation at the bottom of this slide, as well as in the references for a review article that discusses measuring anticholinergic burden. The second recommendation encompasses the remaining medications from Table 3 and adds skeletal muscle relaxants. The recommendation here is to avoid using greater than or equal to 3 CNS active medications, and really to use the smallest number of CNS active medications when possible to avoid increased risk of falls and fractures. This is a strong recommendation with a high quality of evidence. Let's look to the literature to review the study by Gray and colleagues in the Journals of Gerontology, Medical Sciences, published in 2020, titled Association Between Medications Acting on the Central Nervous System and Fall-Related Injuries in Community Dwelling. Older Adults, a New User Cohort Study. The citation is found on the screen here, as well as at the end of the presentation in the reference section. This study used data from the Adult Changes in Thought, ACT study, which was a prospective cohort study conducted in the Seattle, Washington area within Kaiser Permanente. This study recruited patients 65 years of age and older without dementia, and patients were enrolled in 3 waves from 1994 to 2014. Assessments of these patients occurred at enrollment and every 2 years thereafter, to evaluate cognitive function and collect information about demographic characteristics, medical history, health behaviors, and functional measures, end quote. The development of dementia by a patient ended these assessments and data collection. This study used the patient population from the ACT study, but further narrowed the eligibility criteria to include patients that had health plan membership for 1 year before the start of follow-up without evidence of a fall-related injury during that year. Then, they looked at those who had evidence of CNS active medication use during that year and excluded them as well. This resulted in a total sample size of 2,595 patients after an additional 44 patients were removed for having incomplete data. The primary outcome was fall-related injury. Health plan data was used by reviewing pertinent ICD-9 codes and fall-related E-codes, excluding those that occurred with an E-code for motor vehicle accidents. CNS active medication use was determined using pharmacy fill data for the following medication classes: benzodiazepine receptor agonists, benzodiazepines and Z-drugs, and other sedatives, antidepressants, opioids, antipsychotics, skeletal muscle relaxants, and anticholinergics. CNS active medication was further classified by use, standardized daily dose, and type of current use. First, let's look at use. Non-use was defined as no use in the previous year. Remember, this was an inclusion criterion. Current use, recent use defined as within 31 to 90 days of a fall-related injury, and past use defined as within 91 to 365 days of fall-related injury. Standardized daily dose was used to calculate a standard daily dose across different medication use with CNS activity. Patients were then classified as less than 1 SDD low, 1 to less than 2 SDD medium, or greater than or equal to 2 SDD high. Finally, patients who had current use were classified as a newly started medication or ongoing current use. Literature review was used to determine which ongoing parameters would be collected along with fall-related injuries and CNS active medication use to control for confounders. Examples of parameters collected included presence of comorbidities like hypertension, diabetes, cardiovascular disease, and screenings, gait speed, and cognition. Participants were followed until they experienced a fall-related injury, or until follow-up naturally ended, for example, patient no longer covered by insurance plan, stopped participation in research study by choice or end of the study itself, developed dementia, or died. Statistical analysis was conducted using Cox regression models. A separate Cox regression model was used for each of the following scenarios: CNS active medication use based on use and fall-related injury, CNS active medication use based on SDD, and fall-related injury and CNS active medication use based on type of current use versus no use and fall-related injury. Statistical analysis was adjusted for ongoing parameters as previously described identified from the literature review that could have confounded the results. Post hoc analyses were done to determine the influence of individual classes of medications versus CNS active medications in aggregate. Patient baseline characteristics were noted to include a median age of 73 years, slightly more female participants, 54%, with a variety of health conditions. Quote, the most common medication classes were antidepressants, opioids, bladder anticholinergics, and benzodiazepines, and other sedative hypnotics, end quote. In relation to the primary outcome, there were 624 fall-related injuries that occurred over 15,531 total person years of follow-up. Remember, individuals were removed from follow-up once a fall-related injury occurred. The found of those fall-related injuries, quote, current use of any CNS active medication was associated with a greater risk of fall-related injuries compared with non-use, end quote. Quote, among current users, elevated risk was observed for all dose levels, although a dose-response relationship was not observed, end quote. Hazard ratios and confidence intervals are shown on the screen for low dose, medium dose, and high dose, and was compared to no current dose. Finally, quote, among current users, risk of fall-related injury was highest for those who had a newly initiated CNS active medication, end quote. Post hoc analysis did show, quote, new initiation of opioids was associated with an increased risk for fall-related injury, as was prevalent current use, end quote. The hazard ratios and confidence intervals are listed for you in the presentation. No other medication classes were found to be statistically significant at new initiation during post hoc analysis. However, it is important to remember that post hoc analyses are often not powered to provide this evidence. We do know, as outlined by the Beers criteria, that there is already evidence in the literature, moderate strong evidence, that CNS active medication classes included in this trial do in fact increase the risk of falls and fractures. Strengths of the study include the study design and the way that confounding factors were controlled. However, there were also limitations to this study. For example, prescription claims data was collected and used to determine use. However, just because a prescription is picked up doesn't mean that it is used or used as directed. The authors also acknowledge that there may have been some confounding factors like pain as an indicated use for CNS active medications, or pain severity which may increase fall risk, but couldn't be adjusted for based on the data set. Finally, many older individuals will develop dementia, and these patients were excluded from this study. The next article we'll review is the study by Aspinall and colleagues in the Journal of the American Geriatric Society, published in 2019, titled Central Nervous System Medication Burden and Risk of Recurrent Serious Falls and Hip Fractures in Veterans Affairs Nursing Home Residents. The citation is found on the screen here, as well as at the end of the presentation in the reference section. This study was designed to be a nested case control study at a Veterans Health Administration Community Living Center, using historical data between the dates of July 1st, 2005 and June 30th, 2009. Residents were included in the study if they lived at the Veterans Health Administration Community Living Center, were 65 years of age or older, and had a previous history of fall or fracture within 1 year before admission date. Residents were excluded if they were comatose or bedridden, on hospice care, or had been a resident for less than 7 days. A total of 24,869 patients met the inclusion criteria. These patients were followed until the primary outcome occurred. They were discharged from the Community Living Center 1 year after date of admission to Community Living Center or upon the end of the study period. The primary outcome was serious fall or fracture resulting in emergency room visit or hospitalization in residence. Exposure to CNS active medications was defined as using one of the following 5 classes of CNS active medications within 6 days before the primary outcome: antidepressants, including tricyclic, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, antiepileptics, antipsychotics, benzodiazepine receptor agonists, and opioid receptor agonists. The researchers also calculated the CNS standardized daily dose and assigned them to one of 3 categories: 0, 1 to 2.9, and greater than or equal to 3. Finally, they considered confounding factors that could have also contributed to the primary outcome. Statistical analysis was conducted utilizing both univariate and multivariate conditional logistic regression models to examine the relationship between CNS active medications and the primary outcome of serious falls or fractures. 316 residents met the primary outcome and were referred to in the article The Cases. These 316 residents were randomly matched to 4 controls per resident, which brought the total residents included in the statistical analysis to 1,580 residents. The average age of residents included in the statistical analysis was 80 years of age. Resident cases and controls were equally matched on most baseline characteristics. The researchers also found, quote, cases were more likely to receive a medication from 2 or more CNS classes, p equal to 0.009, end quote, and that, quote, 51.9% of cases and 33.8% of controls received an opioid p less than 0.001, end quote. They also found, quote, cases had a mean 4.41 and median 2.5 standardized daily doses. Controls had a mean 3.32 and median 1.91 standardized daily doses, p equal to 0.002. The odds of the primary outcome were also increased in each of the following groups: residents with 3 or more standardized daily doses compared to none, and residents with 3 or more standardized daily doses compared to residents with 0.1 to 2.9 standardized daily doses. Strengths of the study included being able to verify medication administration, as barcode scanning was used. Limitations of the study included not being able to differentiate between new versus chronic medication use, potential missed falls due to coding errors, and decreased external validity due to older data used and patient-specific characteristics. This concludes the CNS active medications, risk of falls and fractures in older individuals. This slide provides the references for the presentation. Thank you.